Assalamu alaikum. Thank you everyone for being connected with me. So in my lecture on pleural effusion, in my previous lecture, I have mentioned you the causes of pleural effusion. There I have discussed that there are two types of pleural effusion actually. One is transudative and another one is exudative. So if the cause is associated with infection or inflammation, then the pleural effusion will be exudative, and if the cause of pleural effusion is associated with non-inflammatory cause such as heart failure or liver cirrhosis or nephrotic syndrome, then the pleural effusion will be transudative. Okay, today we will see again most important chart from Davidson with explanation. I will try my best to give you the brief explanation which will help you very much. Now look at that chart. This is the chart from Davidson. So there are some most common causes of pleural effusion. Okay, so why is the chart important? Whenever a patient comes to you with pleural effusion, then some DD will arise in your mind that what will be the definitive diagnosis. You can reach almost 70 to 80% by taking history, but you need to do some investigation to reach the definitive diagnosis. Okay, so it is important for that to reach the definitive diagnosis and to exclude the differential diagnosis, that means DD. So number one, this is pleural effusion due to tuberculosis. Okay, so if the pleural effusion is due to tuberculosis, the pleural fluid, after aspiration of pleural fluid, you will see that the pleural fluid is like amber color. Okay, amber color. So look at the amber color. This is just like almost amber color. Okay, so whenever you will find the pleural effusion is amber colored, then you think that yes, the primary cause is tuberculosis. Okay, and here is another point. What type of pleural fluid will it be? As tuberculosis is an inflammatory condition, because if there is TB, attack of Mycobacterium tuberculosis, this will lead to, all of you know that, type 4 hypersensitivity. So type 4 hypersensitivity is mediated by CD4 T lymphocyte. So as it is inflammation associated, so the pleural fluid will be, by the basic conception, exudative. Okay, and I have already mentioned that as tuberculosis leads to type 4 hypersensitivity, which is mediated by CD4 lymphocyte, so you will find lymphocyte in pleural fluid. Okay, it is the cellular components. Okay, so now we will see some biochemical components, such as you may find the positive tuberculin test positive, which is done via intradermal purified protein derivatives. Okay, so you may find Mycobacterium tuberculosis in pleural fluid. Okay, after pleural fluid study, and you will find pleural biopsy positive almost 80%. I will show you the pleural biopsy later. Okay, that how does it help us to differentiate that is the pleural effusion is due to malignancy or is the pleural effusion due to tuberculosis. We can diagnose it by pleural biopsy. Okay, so these are the points along the tuberculosis. So another one is malignant disease. If the pleural effusion is due to malignancy, the pleural fluid appearance will be blood stained, because in case of malignancy, what happened in malignancy? You know that angiogenesis, malignant cell causes angiogenesis, and the newly formed blood vessels become very fragile. So this newly formed blood vessels tends to rupture. That's why you will find RBC in the pleural fluid. So the pleural fluid becomes blood stained. Okay, and you will also find some serosal cells. That means, what is the serosal cells? Suppose this is the visceral pleura and this is the parietal pleura. So this pleura is a lining. So the lining epithelial cells of pleural cavity is known as serosal cells. So you may find some serosal cells. And the most important things, you know that in case of malignancy, the tight junction between cells is lost. That means the cell lost its adhesiveness. Okay, so you will find some shaded malignant cell in pleural fluid. It is the most crucial things. And here also you will find pleural biopsy positive. So that means we will find positive pleural biopsy in two cases. One thing is malignancy, another one is tuberculosis. So how can we differentiate between them? Yes, I will show you it later. And you will find if the tuberculosis is due to metastasis, such as someone may have breast cancer, or someone may have liver cancer, or someone may have stomach cancer, and that primary cancer is metastasized into your pleural space, and that metastasized tumor causes pleural effusion. So whenever you will take history from patient, you will definitely find the sign symptoms such as a growth, or such as the weight loss history, or anorexia, chronic fatigue, etc. The sign symptoms that arise during malignancy. Okay, so history is the most important things for us. And another one is cardiac failure. So in case of cardiac failure, pleural fluid will be just straw color, because the cardiac failure will lead to the transudative pleural effusion. There will be no inflammations. That's why it is transudative, and pleural fluid will be straw color. And as well as the pleural lining, so you know that the epithelial cells tends to shed. So you may find some serosal cells, that means the lining epithelial cells of pleura. And if you take the history, patient will give you the history of chronic hypertension, or you may find clinically, that means peripheral edema, exertional dyspnea, raised JBP, or any other things that may give you the clue of having some heart failure conditions. Okay, so pulmonary infarction. Okay, so what causes the pulmonary infarction? Emboli. The number one cause is emboli. Okay, so if you suspect that pleural effusion is due to pulmonary infarction, then you will find some clue that causes emboli formation, such as the patient may suffer from malignancy, or the patient may have had hip fracture, femur fracture, or any large fracture. That means that hip fracture and femur fracture, what will they do? They will do fat emboli formation, and maybe this fat emboli is lodged into this pulmonary circulation, that leads to the pulmonary infarction. And this pulmonary infarction, what will do if there is pulmonary infarction? You know that pulmonary infarction will lead to the hypoxia to lung tissue. So when there is hypoxia, then the lung tissue will be injured. This is called hypoxic cell injury. And whenever there is cell injury, then the subsequent occurrence is inflammation. If inflammation occurs, vascular permeability will be rise, and that's why we will get the exudative pleural effusion by the basic conception. And so you may ask a question that why will you find blood? That means the pleural effusion due to pulmonary infarction will be blood stained. Yes, because whenever there is hypoxia, the blood vessels swell. So look at my virtual whiteboard. Suppose this is in blood vessels. So you know that the innermost lining of blood vessels is endothelial cells. The innermost lining is endothelial cells, and the middle layer is smooth muscle cells layer. Okay, all of you know that I'm just writing it for formality for the beginners. And now this is the smooth muscle layer, and the outermost layer of blood vessels is tunicula adventitia. Okay, so suppose this is the tunicula adventitia. Okay, so suppose the obstruction is here, that means the emboli. This is the emboli. So the blood cannot move forward, so the blood vessels itself suffering from hypoxia. So what happened? This hypoxic condition will lead to the decreased strength of this vessel wall. Blood vessel wall strength will lost. That means the blood vessels will be less strength, less strong. So the blood vessels tends to rupture easily. So the blood vessels will be ruptured. And what will happen if the blood vessel is ruptured? The RBC between here, okay, or the bloods from the venular portion, because a capillary is formed by two ends. One is arteriolar end and the another one is venular end. So this is pulmonary capillary. Okay, so which RBC was present already there, due to the decreased strength of blood vessel will be ruptured and the RBC come outside of the blood vessels and they will take place into pleural cavity. Okay, suppose this is the visceral pleura and this is the parietal pleura. So you will find the RBC here, the RBC here. So this hypoxic condition ultimately lead to the decreased strength of blood vessels wall. That's why you are finding RBC here. Okay, now come back again. Okay, so I have already told it, red blood cell and evidence of pulmonary infarction such as SORS, prolonged bed rest or hip fracture or any other things. And another one is rheumatoid disease. You will find the pleural fluid will be just turbid, some extent cloudy appearance. Okay, because the rheumatoid disease, what will be the condition of pleural fluid, exudative or transudative? Definitely exudative, because the rheumatoid disease, it is actually a autoimmune type disease. Okay, so there is happening antigen antibody complex formation, and this antigen antibody complex formation will lead to the complement activation. Ultimately neutrophil chemotaxis will be happened. That's why this chemokine and some inflammatory mediators will released at that site. This lead to the exudative, thus increased vascular permeability. This increased vascular permeability will lead to exudative pleural effusion formation. And in case of this antigen antibody complex, that's why you will find lymphocyte also. And here you can see the basic forms. The lymphocyte, occasionally some polymorphs. Okay, so we will find lymphocyte mainly. Okay, so here some biological markers such as rheumatoid factors and anti-cyclic cytolinated peptide also be found. So, and low glucose level, it is one important thing, low glucose level in pleural fluid. And in case of SLE, same, SLE and rheumatoid arthritis, both of them are antigen antibody reaction, so complement activation, so neutrophil chemotaxis, so inflammation will happen. Then ultimately what will be exudative pleural fluid, so it will also be serous and turbid, same. And you will find here just like same lymphocyte. Okay, and you will find some history of SLE such as vitiligo or the malar rash or the other sign symptoms of SLE. Okay, so it is important to taking history and do a good clinical examination on patient. So another one is thoracic duct obstruction. It is a cardinal type of pleural effusion. That means the pleural fluid will be milky appearance. Because what will lead to the pleural effusion? This is due to the thoracic duct obstruction. That means lymph is produced but cannot be drained due to the blockade of thoracic duct. That's why we will get huge chylomicron in pleural fluid. This chylomicron is actually a fat droplet. Okay, so what will be this chylomicron will lead to the milky appearance pleural fluid. Okay, in case of pneumonia pleural effusion, that means the primary cause is pneumonia, and this pneumonia has developed inflammation, and this inflammation has developed formation of pleural fluid, pleural effusion. So as the pneumonia is a bacterial infection, so you will find predominant neutrophil infiltration in the pleural fluid, and as it is inflammatory associated, so you will find the exudative pleural effusion, exudative. Okay, and you may find microorganism by doing gram stain of that pleural fluid sample. Okay, so this is all about the chart. I have tried my best to explain you it briefly. So now look at the color of pleural fluid. Here is some example. This is a straw color pleural fluid. So what will be the cause? Heart failure. Okay, that means it is transudative pleural effusion. It is transudative pleural effusion. This is blood stained pleural effusion is found in 3 cases according to Davidson. Number 1 is malignancy, number 2 is pulmonary infarction, number 3 is acute pancreatitis. What will happen in case of acute pancreatitis? I will explain it later, just later. And this is purulent, or this is called purulent type of pleural fluid. This is found in pneumonia. I have shown you it just previously. Okay, pneumonia. And this is chylous or milky appearance. So this is due to thoracic duct obstruction. So all about the color of pleural fluid. Now let's to the point. What is happened in case of pancreatitis? Look at the diagram. This is the diaphragm. The black one is diaphragm. Okay, and this is the pancreas, and this is the main pancreatic duct. This is the common bile duct. This 2 duct is fused in this position, and they are going to open into second part of duodenum through major, through all of you know that major duodenal papilla. But suppose the patient is suffering from acute pancreatitis. Suppose this is due to gallstone obstruction of this main pancreatic duct. So the pancreas is continuously synthesizing the pancreatic enzyme, and you know that the pancreatic enzyme is proteolytic, lipolytic, and amylase enzyme also. That means the pancreatic enzyme has the capability to destroy everything because it is a proteolytic enzyme. It can damage the collagen fiber, elastin fiber, and the cell membrane. That means the protective all layers can be destroyed by pancreatic enzyme because it is proteolytic. That's why the pancreatic enzyme is continuously being synthesized in pancreas, but they are not able to secrete it because the main pathway is obstructed by a gallstone. So what will happen? After some days or some months, the intracanalicular pressure within the main pancreatic duct will rise. So the main pancreatic duct will be burst out. That means the pancreatic enzyme now released, and they will begin to release into the surrounding structure rather than going to the duodenum. Now they are going to surrounding structure. So this pancreatic enzyme will take place into such as they will tear the omentum, and they will begin to accumulate in peritoneal cavity. Also they will move upward and they will destroy the surrounding structure. Then they will destroy the diaphragm, then they will destroy the pleural cavity, then ultimately they will form a fistula. That means there will be formation of fistula between the main pancreatic duct and pleural cavity. Look at this tunnel. This is fistula because this pancreatic enzyme continuously damaging the supportive structure, and it will form a tunnel. So the pancreatic enzyme now take their place in pleural cavity. So what will happen if this pancreatic enzyme take place in pleural cavity? As it is proteolytic, it will damage the lung tissue, surrounding lung tissue. It will damage it. So if cell injury occur, the next subsequent steps is inflammation will happen. If inflammation is happened, so inflammation, what will do inflammation, or what thing will happen in case of inflammatory response? Vascular permeability will be increased. That's why increased vascular permeability will lead to the formation of exudative pleural effusion. And I have already told, as pancreatic enzyme is proteolytic, it will damage the blood vessels wall, just like as in case of pulmonary infarction. Look at my whiteboard. Just like us, suppose this is, here is pancreatic enzyme, so this pancreatic enzyme will damage the vascular wall, so RBC will leak out from the circulation and they will take place into this pleural space. This is pleural space. Okay, so you will find blood stained pleural effusion, blood stained pleural effusion. Okay, now come to the next point. What will be the symptoms of pleural effusion? So you have to think that pleural effusion itself is not primary disease. There are some primary disease, and that primary disease lead to the formation of pleural effusion, such as someone is suffering from tuberculosis. So the tuberculosis is primary disease, and subsequently there will be pleural effusion formation. Someone may suffering from heart failure, and due to this heart failure, now he or she has developed pleural effusion. Someone may suffer from malignancy. Now due to that malignancy, now the patient has developed pleural effusion. So there is usually a primary disease, and that primary disease now lead to the pleural effusion formation. So the patient will give you the history of that primary disease. If he or she is suffering from tuberculosis, then you will find the signs symptoms of TB, or you will find the signs symptoms of malignancy, or you will find the signs symptoms of SLE, heart failure, etc., or pneumonia. Okay, so this is not my headache. My headache is what is the actual symptoms related to pleural effusion. You know that the basic conception I have already explained it in my first class. That was, suppose this is lungs and this is visceral pleura and this is parietal pleura. So the pleural fluid is here. This is the pleural fluid. That means due to this accumulation of fluid outside of the lung cannot expand adequately. So the patient will give you the history of breathlessness, because he or she cannot get enough oxygenation. Okay, and during inspiration, you know that during inspiration what will happen? During inspiration, lung is expanding. During inspiration, lung is expanding. So the intrapleural pressure will rise. Intrapleural pressure will rise, and the nerve ending which is supplying the pleural cavity, they will be irritated. That's why the chest pain will exacerbate. So he or she will give you the history of chest pain which exacerbates during inspiration. This is important term, during inspirations. Okay, because during inspiration lung is expanding and the parietal pleura, here is parietal pleura and this is the visceral pleura. Now I am inspiring, so that it is come just close to the parietal pleura and irritating it, because there is a fluid, pressure will rise. Okay, so the chest pain will exacerbate. Okay, now comes to the point of and he also give you the history of cough. It may be dry or productive, according to, it depends on the primary disease. Either the cough will be dry or productive. Okay, now comes to the clinical examination. That means we know that in case of respiratory examination, we will do the clinical examination under 4 headings: on inspection, on palpation, on percussion, on auscultation. On inspection, what will you see? You will see that the patient is tachypneic, because he is trying to get enough oxygen, because the lung cannot expand adequately. That's why he will try to compensate it by increasing respiratory rate. Okay, and the next one is palpation. In in the site of pleural effusion you will get decreased expansion of lung. You can already understand it, I think. And in case of percussion, whenever you will do percussion, you will find the stony dull. It is totally depends on your clinical practice. If you do percussion on a patient having pleural effusion, you will get a stony dull. It is just by doing you have to capture it. It is not possible just telling. Okay. Now another one is auscultation. If you auscultate it, what is the basic conception? Because look at the figure. Because suppose this is the lung field. Okay, and this is the chest wall. This is the chest wall. Okay, now there is the pleural fluid. Suppose this is the pleural fluid. Okay, now if you auscultate the chest, that means this is your lucrative Leitman stethoscope. Okay, now what is happening there? There is a barrier between your stethoscope and the lung field. There is a barrier. What is the barrier? The fluid, pleural fluid. So the movement of airflow in the lung cannot be heard due to the fluid. That means the sound of air movement within lung is not transmitted adequately in your stethoscope due to the intermediate fluid. That's why you will get absent breath sound. This is the explanation, and this is some extent atypical, that you may find bronchial breathing not at the site of pleural effusion, just above the effusion. Suppose look at the picture again. Suppose the pleural fluid, upper level of pleural fluid is here. Suppose so, upper level of pleural fluid is here. So if you place the stethoscope here, you will get decreased vesicular sound, or that means decreased breath sound. But if you place the stethoscope here, if you place the stethoscope just above the pleural effusion, you may get the bronchial breathing. Okay, so you may not go, you shouldn't be confused with that it may be some consolidation. No, you should examine it carefully. Okay, so already you looked the chest x-ray P view. This is the pleural effusion. So how can you understand that it is due to pleural effusion? Yes, there are some points. Okay, there are some points again pleural effusion. How can you identify? At first, the costophrenic angle will be obliterated. Look at the figure. The costophrenic angle is absent, and there is a concave line, and the line is extending towards axilla. This is right axilla. This is right axilla. So this concave line, and this is extending towards axilla. Okay, and this is homogeneous opacity. Okay, radio opaque. Okay, so this is the points such as curved shadow at the lung base, blunting costophrenic angle, that means obliteration of costophrenic angle, ascending towards axilla. Okay, so how much pleural fluid is required to be detected in chest x-ray? At least 200 ml. If the pleural fluid is less than 200 ml, you may not detect it by doing chest x-ray. Then what will you do? Yes, that's why ultrasonography of chest is best. USG of chest can detect pleural effusion as little as 100 ml. Okay, 100 ml of fluid, and it will also help you if you're doing chest x-ray, and if you say the patient to move side by side, then you are seeing by ultrasonography probe, you will see that the moving fluid. Okay, and also by doing ultrasonography, you as well as you can detect little amount of pleural fluid, and also you can detect the pleural fluid is either transudative or exudative. So look at some picture of ultrasonography of chest. At first I want to show you the typical ultrasonography. So look at the picture. So in case of ultrasonography, we call the echogenicity. Anechoic, that means no echogenicity, that will be black. Suppose this is anechoic, black. This is hyperechoic, white. Okay, so this is called echogenicity. We categorize the ultrasonography according to echogenicity. So this is liver, and this hyperechoic is diaphragm, and this is the base of lung, and this is a spine. This is a spine. Okay, so this anechoic black shadow, it is the pleural effusion. Look at the picture again. Another, this is mild pleural effusion. Small or less amount of pleural fluid is present there. Now look at that picture. This is liver, echoic structure, and this is hyperechoic. This is diaphragm, and this is the base of the lung. It is also hyperechoic, and this is anechoic portion, black. This is the pleural fluid, massive pleural effusion here. Okay, so look at this 4 diagram. Look at this pleural effusion. I think all of you can understanding now. This is the pleural effusion here. This is, now this pleural effusion is anechoic, totally black. It is called anechoic. So whenever you will get totally anechoic, then it is due to transudative pleural effusion. If the echogenicity of pleural fluid is increased, that you may suspect, yes, it is due to exudative pleural effusion. So look at the picture. This pleural effusion is more echoic than this one, and this pleural effusion is atypical. Here you can see this is the pleural effusion, and this is septate like appearance. Here you can see some septa, septate like appearance, septa, 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 septa. Okay, just like septate. And whenever you will get septate pleural fluid, yes, this is definitely exudative pleural effusion, exudative. And here look at the picture. This is the pleural fluid. This is more echoic than the previous one, so it is echoic, exudative pleural effusion. Okay, so what is the treatment of pleural effusion? Aspiration of pleural fluid, but remember it, very important, you should not do more than 1.5 liter pleural fluid aspiration, because if you do more than 1.5 liter fluid aspiration, it may lead to formation of pulmonary edema. That means you are doing something for the betterment of patient, but now the patient is suffering from pulmonary edema. So can you tell me that how does this lead to the formation of pulmonary edema if we do more than 1.5 liter pleural fluid aspiration? This is my question to you. Please comment me, so I will be grateful, and the class will be more enjoyable for me if we do both sides of discussion. Okay, so we will do some investigations such as total count and differential count. Okay, so by doing this differential count, we can suspect either this primary condition, that means this inflammatory condition, is due to bacterial cause or viral cause. We will do ESR to see the inflammation rate, and we will do chest X-ray for detecting is there any pleural effusion, or ultrasonography or chest, and we will do pleural fluid aspiration. For doing DD, that I have discussed in my first portion of this class, that means either it is due to tuberculosis. If it is TB, you will get a raised amount of adenosine deaminase. Okay, you may get the Mycobacterium tuberculosis. If it is malignancy, you will get, and after taking pleural fluid, you will get the shaded malignant cell. If it is due to pneumonia, you may get the microorganism associated with pneumonia. And in case of rheumatoid factor or presence of lymphocytes, neutrophil in the pleural fluid. So this is all about information you will get by taking pleural fluid aspiration. So it is necessary. That means pleural fluid aspiration is a treatment as well as a investigative purposes. Okay, and we will do pleural biopsy. Yes, I forgotten it to show you that pleural biopsy. Yes, this is the pleural biopsy. So look at that picture. We are now within the pleural cavity. Okay, here you can see this is a rough engorgement of this rough engorgement. Look at the diagram with concentration. You can easily see this is, we are within pleural cavity. Suppose you are seeing the pleural cavity and here some haphazard engorgement, enlargement, okay, and some blood tinged space. So this is almost due to malignancy. Okay, and in case of TB, the pleural biopsy will be, that means the pleura will be diffusely affected in case of tuberculosis, and the appearance will be patchy like appearance. But in case of malignancy, pleural involvement will be loculated in certain area, and that will be more abnormal, haphazard and blood stained. Okay, because the newly formed blood vessels angiogenesis and they are tends to ruptured. Okay, so this is all about the pleural biopsy. Okay, so pleural biopsy actually done to differentiate between tuberculosis and malignancy. So I have tried my best. If I make any mistake, please make myself corrected, and I will be grateful to all of you, and keep me in your prayer. Thank you. See you again. Allah Hafiz.